who's the Executive Director of the Mental Illness Research, Education, and Clinical Center, Vice Chair for VA Affairs at Mount Sinai School of Medicine, and a Professor of Psychiatry at the Mount Sinai School of Medicine. Larry will be our moderator for the day. Thank you.
Thanks, Perry, for organizing this conference, and really to NEA-BPD for all that they've done in this conference and previous conferences. And we'll now move into the science portion after, I thought, moving tribute to Wayne, who was so, I think, central to efforts in this area. So I'm going to briefly introduce each of the speakers. They'll speak for about 50 minutes or so, and then we will go around with the green cards that you have in your programs to pick any questions up that people want to write down, so that we'll then have an opportunity to address those questions to the speaker. And then we'll have a more general discussion towards the end of the day. So I want to introduce now Harold Koningsberg, who's a professor of psychiatry at Mount Sinai School of Medicine, who's going to be talking about imaging studies of emotion processing in borderline personality disorder. He brings a long-standing interest in initially psychodynamics, treatment of borderline, was at Cornell for many years, actually had a background in physics as well, and has combined his scientific interest, his psychotherapeutic interest in borderline to study in depth, using imaging procedures, how emotional processing works in borderline personality disorder and what can go wrong. Harold?
Thanks, Larry. I have actually some revisions to my slides, some data that I'll show you that's really literally hot off the press. So I'm going to install, take a moment to install the new slides. We just want to install this. Okay, thanks very much. So I'm going to talk today about neuroimaging studies of emotion processing, emotion regulation in borderline personality disorder. And we all know that emotional instability or affective instability is a major part of the borderline disorder. And it's characterized, as you know, by rapid shifts in mood from depression to anxiety or anger, or back to baseline and back and forth. And these moods last for short periods of time, hours, rarely days at a time, and then there's a swing to another mood. And the mood shifts are responsive to interpersonal situations, to rejections, abandonment, losses, experiences of envy, abuse experiences. So these emotional shifts are really one of the hallmark features of the borderline disorder, and they're responsible for a tremendous amount of the turmoil, the interpersonal turmoil that borderline patients struggle with every day. And in addition to that, the emotional instability is associated with many of the other borderline symptoms that we all know about. We looked, for example, can you hear me now? Yeah, this way I can move around a little bit. We looked at the association between affective instability as measured in a series of questionnaires to patients and the typical borderline symptoms. And these numbers are the correlations between affective instability and specific borderline symptoms. You see that there's a high and significant correlation with suicide threats, gestures, and acts, with the identity disturbance in BPD, with the feelings of chronic emptiness and boredom, as well as the inappropriate anger. So emotional instability is really closely related to a large spectrum of the borderline symptoms. Interestingly enough, we also looked at impulsive aggression and the correlation with the symptoms. And for example, for suicide threats and gestures, while affective instability is very significantly associated, to our surprise, impulsive aggression was not particularly associated with suicide threats, gestures, and acts. We then looked at the emotional instability in BPD in a more fine-grained way using an instrument called the affective lability scale, which looks at shifts in specific affects back and forth. And we compared those shifts in borderline patients to those in patients with other personality disorders. And it appears that the affective shifts in BPD are really related to specifically the affects of anxiety, anger, and shifts between depression and anxiety. And we know a little bit about the genetics of affective instability. First, as you know, twin studies have shown the importance of genetic as well as environmental factors in BPD. But in addition to that, there are more specific studies that have shown a genetic association to affective instability. Work done here at Sinai back in 1991 by Jeremy Silverman showed that affective instability runs in families of borderline patients. And twin studies have shown high heritability for affective instability in the borderline population, a heritability coefficient of 0.45, which is a substantial number. Now I'm going to talk about studies of emotion regulation in BPD using functional neuroimaging. And let me just say a word about that. Functional neuroimaging, and I'm going to talk specifically about functional MRI, uses the MRI technology to look not simply at the anatomic structure of the brain, which, as you know, MRI is very good at getting very high-resolution images of the anatomy of the brain. But if you vary the magnetic fields and the radiofrequency fields in a very specific way, you can look not only at the structure of the brain, but at the brain as it's functioning. You can see which regions of the brain are getting fresh blood, which means from moment to moment, which regions of the brain are active when certain tasks are going on. So you can look in the brain in real time and see what's happening as someone, in the case of what I'm going to be talking about, is processing emotional cues. Now, I wanted to show you this picture of an MRI scanner. We're looking, and I'm going to be talking about emotional reactions in interpersonal situations. I wanted to show you the kind of scanner we use because some of you may have seen this cartoon in the New Yorker recently of another fMRI scanner. This is the MRI of love. It's kind of got a heart-shaped bore. And while this type of device seems particularly good for looking at emotional interactions, these two people seem in quite a bit of distress, we're not using a machine like this. So we want to look at the differences between healthy controls and borderline patients in the way their brains are functionally active during emotion processing. And I'm going to talk about some studies we've done looking in two different aspects of this. First, feeling emotion in borderline patients, how the brains operate when they're just passively letting themselves, emotions kind of flow over them. And second, controlling emotions in BPD. So first, let me talk about feeling. In the study I'm going to describe to you, we showed borderline patients and healthy controls photographs which are selected to elicit strong emotional reactions. These pictures come from the International Affective Picture System. It's a group of some 600 pictures now that Peter Lang in Florida and his group have gotten together, which stimulate either negative emotional reactions or positive emotional reactions, or there's some neutral pictures. And he's standardized these pictures, gotten norms on how people respond to them, using hundreds of college students in the University of Florida. And these are well known and used in research. And so we had our subjects come into the scanner, and while they were in the scanner, we asked them to look at the pictures and just to allow themselves to feel whatever emotions the pictures stimulated. The study that we did, which is a rather large study for this kind of work, looked at 19 borderline patients and 17 controls. They're matched in age, and they're equally divided between men and women. And this is the design of the experiment. We first showed people a series of positive pictures. This is an example of a positive IAPS picture. We showed them a series of 5 pictures. Each picture is on the screen for 6 seconds, and so a series of 5 positive pictures for 30 seconds. Then the screen just says relax for 30 seconds. People go back to baseline. And then we showed them a series of negative pictures. Again, 5 pictures each for 6 seconds. We repeated this 4 more times so that they saw a total of 25 positive pictures and 25 negative pictures. Now let me show you what we found for differences between the 2 groups. These are images for the brains of the borderline patients and the healthy controls. This is the brain looking at the person from the front, and this is looking from the back as he's walking away from you. This is the right side of the brain, the left side of the brain, looking from the bottom up and looking from the top down. And you see, as you compare the borderline images to the healthy volunteers, the activations when the subjects are looking at negative pictures minus when they were looking at positive pictures. So we subtract out the effect of just looking at pictures, it seems, of people, and we're looking at the difference, the emotional valence difference. And the sort of most immediately striking thing here is in the occipital area of the brain, the back of the brain. These are the normal controls, and these are the borderline patients. And you see how much more activity there is here in the primary visual areas. And I'm going to talk some more about that. But let me go and show you some more detailed pictures of what's going on inside the brain by showing you some slices of the brain. And to simplify, I want to separate this into when the people are looking at negative pictures compared to the resting state, and then the positive pictures compared to the resting state. So these are pictures of the brain. Now these are cross sections with a plane this way. The brain is cut this way. And what you see here are regions of the brain where the borderline patients are more actively working than the healthy controls when they're looking at negative scenes compared to rest. And you see this area here, the amygdala, is lit up. So the borderlines are more active in the amygdala. The amygdala is an almond-shaped structure. We have one on each side of the brain. It's sort of behind our temples. And it's a central part of the brain that's involved in emotion processing. When emotional scenes are seen, this part of the brain makes an assessment of the emotional salience of that scene. And it also responds particularly to threatening situations. When people are in unpleasant or dangerous situations, fearful situations, the amygdala is very active. It's sort of part of an alarm system. It assesses people's facial expressions, it looks and makes these kinds of early assessments of the emotional significance of something that's happening. And we see that in the borderline patients, this area is more activated. We also find that the fusiform gyrus area is more activated, and this is a region that's also involved in facial processing. Again, assessing what you read in people's faces. And these are some more views of the insides of the brains. Now these are cross-sections. This is sort of the brain in profile. This is the front of the head, and this is the back of the head. And again, you see that the borderline patients are more active in these visual areas, the cuneus, the middle occipital gyrus. These are primary visual areas, sort of the first parts of the brain that begin to process visual stimuli. An area here that I want to talk about some more, the superior temporal gyrus. I'll say a little bit more about what that area does. And also we see in these frontal areas in what's called the motor cortex, which is an area that's involved in activity, in taking physical actions. And then we wanted to look at the question the other way around and see what areas do healthy people activate more strongly than borderline people when they're looking at these negative emotional scenes. And here we see that the healthy controls activate the middle temporal gyrus. This is an area that is involved, among other things, in retrieval of memory, sort of past experience. So it suggests that the healthy controls may be assessing the emotional significance of something they're looking at by drawing from their past experience, putting into context. And this area in the middle frontal gyrus, called Brodmann area 46, which is an area of sort of high-level cognitive processing. It's an area of the brain that works with the highest level of abstractions, that plans, that integrates things. So the healthy controls are using these sort of higher cognitive areas more actively. Now, then we wanted to see what happens when people are looking at positive pictures compared to rest. And this is, again, what you see in the brains of borderline patients when they're looking at positive pictures. Again, this middle temporal gyrus, some activity in the cerebellum. The cerebellum, for years people said, and this is what I was taught in medical school, that the cerebellum's only function was coordination, to make sure that you're physically coordinated as you walk down the street. But it turns out that the cerebellum has as many neurons as the whole rest of the brain, so it must be doing a lot more. And recently people have found that the cerebellum is in fact involved, among other things, in emotional processing. And then where do healthy controls activate more strongly than borderlines when they're looking at positive pictures? And we found a strong activation signal in what's called the caudate nucleus on both sides of the brain. This is an area that's involved in motor activity and also in the part of the brain that registers pleasurable experiences. And so we'll come back to that. So it looks like this part of the brain that's involved in pleasure is more active in the healthy controls than the borderlines when they're looking at pleasant, positive pictures. So we've looked at a lot of different blobs across the brain. To kind of summarize what we've seen so far is that when viewing negative pictures compared to rest, the borderline patients show more activity in these primary visual areas in the back of the brain, in the amygdala and the fusiform gyrus, these areas that are involved in assigning emotional salience, in the superior temporal gyrus, which I promised I would talk to you about some more, and in the premotor cortex. And healthy volunteers show more activation in a region of the brain. I didn't show you a picture of this, of the insula. This is a part of the brain that's also involved in emotion processing. So when the healthy volunteers are looking at negative pictures, they show more insula activation than the borderline patients. This is an interesting finding, and recently Antonia New, who's going to be speaking to you later, has reported on a study that she did looking at people with post-traumatic stress disorder. And she compared people who were exposed to trauma, and some people who are exposed to trauma go on and develop PTSD, and some people don't. These people seem to be in some ways resilient. And she compared the resilient and the non-resilient people exposed to trauma and found that the resilient people showed increased activity in the insula, the same area that we find the healthy controls are showing more activity during the negative pictures. Also, the middle temporal gyrus and the middle frontal gyrus, this area 46, this higher level cognitive processing area, is active in the healthy controls. And to positive pictures, it's rather similar. The borderlines show more activity in these premotor cortex, the superior temporal gyrus, inferior frontal, the cerebellum, and the healthy volunteers, more activity in the caudate, the pleasure center. So how can we sort of put this together and understand this? Well, we saw that the borderline patients showed increased activity in both the amygdala and these primary visual areas in the back of the brain. It's not surprising that both areas would go up because there are feedback connections from the amygdala to the primary visual areas. This makes sense that when the brain is activated and gets a signal that something, is emotionally important, that it would turn up the gain in the visual systems to become sort of increasingly alert, increasingly aware of the visual stimuli. And one could think then that borderline patients have this extremely high, the gain is turned up extremely high in the visual processing areas. And Duncan and Barrett have actually suggested that this very high gain in the visual areas can make people sensitive and aware of extremely subtle visual cues. And people have, in sort of normal interactions, a whole gamut of facial expressions. There are also a series of what are called microfacial expressions, kind of small muscle shifts in the face, very rapid shifts. And Barrett and Duncan have actually proposed that with this hyperactive visual system, borderline patients may be more able to read microfacial expressions that healthy controls don't even notice. And this may be related to borderline patients' great interpersonal sensitivity. They may be tuning in to very small gestures, facial motions of disturbance, of irritation in other people that most people don't actually notice. Now I wanted to talk about this process of how emotions are processed in the brain. And we've learned from studies of fear processing system, which is the emotional system that's really the best studied, that there are two pathways through which fear is processed. One is a quick, reflexive pathway, and the other is a slow, more thoughtful pathway. And this makes sense. If you put your hand on a hot stove, you want a reflex to pull your hand back before you even have time to think about the stove being hot. Similarly, if there's a threatening animal that's about to attack you, you want to instantly start to run before you even have time to assess the situation. So there's this fast pathway. But then you also want to be able to assess an emotional situation in a sort of more thoughtful way, putting it into perspective, drawing upon previous experience. And Satput and Lieberman have proposed that the brain's emotional processing is divided really into two systems. A reflexive system, which they call X, the X system, because reflex has an X in it, and a reflective system, which they call the C system, because reflective has a C in it. And the reflexive system is this fast operating system. It's wired in. There isn't learning that is needed to lay it down. It's phylogenetically older. You find it in more primitive animals. And then the C system, the reflective system, that involves more thought, involves a kind of self-conscious awareness, involves drawing upon previous experience to assess a situation, and is more subject to learning from experience. And Sethwood and Lieberman have proposed that networks in the brain, that different networks in the brain are involved in these reflexive and reflective processes. The reflective processes are the areas that sort of outlined in light color, and the reflective are the areas that are outlined in the darker color. So getting back to our data and to the superior temporal gyrus, you remember that we saw that the STG, the superior temporal gyrus, was more activated in the borderlines than in the controls when they were looking at negative pictures. And the STG has been implicated as part of this reflexive system, this fast operating, instant acting system. So it looks as though when borderline patients are exposed to negative emotional stimuli, they tend to be using kind of more of a reflex response system than the healthy controls. The healthy controls activated more of the middle temporal gyrus and this cognitive area, DA46. Now, the middle temporal gyrus plays a role in retrieval of memories of people's past experiences. So that the healthy controls, when they're looking at a negative emotional image, seem to be activating parts of the brain that look back at previous experiences with similar kinds of situations to assess it. And also are using this kind of highest, the parts of the brain that deal with highest abstraction and cognitive processing. We saw that when responding to healthy pictures, the healthy controls activated the caudate more than the borderlines, and the caudate may be involved more in pleasurable experiences. There was a study, for example, that showed activation of the caudate in romantic love. Well, now the logical next step to go with this is to look at what goes on when people are actually trying to control their emotional reactions. So far, I've just been talking about letting the feelings kind of wash over you. But we all try to deal with negative emotional experiences by trying to control them, keep them in line. And we have mental processes that we use to do that. And there are a number of cognitive processes that we can use to control negative reactions. One is a kind of a cognitive reframing. You know, something terrible happens to us in our lives, and we may be able to say, well, you know, this is an awful thing, but it's a good learning experience. I will grow from this experience. That would be an example of a kind of cognitive reframing. With photographs that we show people, an example I can give you is that one of the IAPS pictures shows 3 women standing outside of a church, and they're sobbing. And your initial reaction to the picture is someone's died, they're coming from a funeral. But you could reframe that picture by saying they're coming from a wedding, and these are tears of joy. So you can take a particular situation and use your thought processes to kind of reframe it as a way of reducing your emotional reactions. Another way of cognitively reducing emotional reactions can be using what I'm calling distancing strategies. You know, when the surgeon in the emergency room has to come out and attend to somebody who's just been wheeled in from a horrible car accident, and you know sees the most gruesome kind of scene, that surgeon needs to, you know, not get emotionally involved to be able to function effectively, and needs to be able to kind of emotionally distance himself from what's going on. And we all have these abilities to emotionally distance ourselves when we need to. So what we wanted to look at is how the brains of borderline patients and healthy controls are operating when they're trying to suppress their emotional reactions to negative pictures. And we wanted to focus on one particular strategy, the second strategy I described, the emotional distancing strategy. The reason we chose that strategy is that our clinical sense is that people with borderline disorders often have trouble kind of distancing. They kind of get like emotionally very over-involved in situations. So we thought that would be a particularly interesting strategy to look at. So we used a technique that was developed by a collaborator of ours, Kevin Oxner, who looked at these cognitive control processes. And the strategy that we used is this detachment strategy. What we told our subjects is, we're going to show you some pictures and assume the role of a clinical detached observer, or see the scene as though you're looking at it as an anthropologist. And people quickly catch on to this. We have them practice this looking at pictures on a laptop computer before they go into the scanner, and people, get the idea and can do it, pretty effectively. Now, this is work that Kevin Oxford did in healthy people. And he found that when healthy people are using this cognitive control strategy, they activate medial parts of the frontal lobe. And one of the areas that they activate is right here, this bright spot. And this is an area and a part of the brain that you'll hear a lot more about, called the anterior cingulate cortex. It's a strip of, this is a cross-section of the brain really in the middle of the head. And this is a strip of the brain that just sort of curves around here. And it's involved in emotion regulation, among other things. And Kevin Oxner found this area lights up when healthy people are trying to suppress their emotional reactions. And in fact, when he looked at the degree to which individuals could downregulate their negative emotions, he found a correlation between that and how activated this area was. So that the more they were able to drop their negative affect, the more they were activating this region of the brain. So this is our experiment. We brought people into the scanner, and we showed them a series of photographs, either negative or neutral pictures. And before we showed them each picture, we gave them an instruction over earphones. And the instruction for half of the pictures said, just look, and for half of the pictures it said, suppress. So we told them, if you get the instruction, look, just look at the picture, just let yourself feel whatever the feelings are. If you get the suppress instruction, use this distancing strategy to downregulate your emotional reactions. So they got the instruction, then they saw the picture for 10 seconds, during which time they used the strategy that they were instructed to use. Then the picture went off the screen, and we asked them to rate how positively or negatively they felt about that picture by pushing one of 5 buttons for very negative or very positive. So that was to rate it after they had carried out the strategy. And then there's a little pause period before the next picture comes. We showed them a whole series of about 96 pictures. And let me show you what we found. Now, I reported on preliminary data last year in South Carolina. We've since doubled our sample size, and so the new data that really is hot off the press that I haven't shown before is based on this larger sample of 18 borderline patients and 16 controls. They're matched in age, and about half are male and half are female. And let me walk you through what we saw here. These are images, again, of looking at the difference in activation when people are suppressing compared to when they're just looking. So we subtract the activations when they're looking from the activations for the pictures that they're suppressing. And we're comparing the healthy controls to the borderlines. So the areas that are lit up here are areas where healthy controls are activating more than borderline patients when they're suppressing compared to looking. And you see we're getting activation here in the anterior cingulate cortex. And that's the area that Kevin Oxner found was involved when healthy people are trying to downregulate their emotions. This area also has a controlling effect on the amygdala, so that when this area is increasingly active, the amygdala gets downregulated. And this would make sense that when one is trying to suppress their negative feelings, one wants to sort of turn down the activity of the amygdala, which is this kind of alarm negative system in the brain. So I'll come back to that when I show you some pictures of the amygdala. But this area was activated, and we also found activation in this region here, which is the intraparietal sulcus. You see it's on both sides. And this is an area that's involved in the allocation of attention. So when we're doing a task or looking at something, our brains are deciding how much we want to focus our attention on that particular task. And here we find that in the healthy controls, when we're asking them to distance themselves, they're activating this attention-regulating area, which again makes sense, because if you're trying to distance yourself, you're going to do this by trying to control your attention and withdraw your attention. So the borderline patients are not activating these areas as much as healthy controls. And this shows from our pilot data, just gives you a direct comparison of the activity. The blue lines are the healthy subjects, and the red lines are the borderline subjects. And this is the activation in the anterior cingulate when both groups are just looking at pictures or when they've gotten the suppress instruction. And you see that when they're both looking, both groups are activating about the same amount in the anterior cingulate. But when they're suppressing, the healthy controls are increasing the activity of the anterior cingulate. And the borderline patients don't seem to be able to do that. And now I want to get back to the amygdala. You know, what I said before is that if people are effectively suppressing their emotional reactions, then we would expect to see the amygdala's activity downregulated. Well, this is a picture showing regions of the brain where the borderlines are more active than the healthy controls during suppression. And we find that in the amygdala, the borderlines are more active, telling us that they weren't able to as effectively suppress. So the differences we saw are that healthy controls can activate more actively this intraparietal sulcus region, which is involved in control of attention. And this may account for why healthy controls are better able to cognitively detach from upsetting emotional situations. Maybe this is related to the defensive operation that psychoanalysts refer to as isolation of affect. And now I want to talk a little bit more about the cingulate. So this is another picture of where the anterior cingulate is located. And what we saw were that borderline patients seemed to lack the ability to recruit these brain regions, the anterior cingulate, that are normally used by healthy controls to downregulate their emotions. And the failure to be able to call upon the anterior cingulate may also reflect some difficulty with conflict processing. And I want to talk about that for a minute because that's something else that's very relevant to borderline. One of the features that people have described with borderline patients for years, one of sort of the most striking things when you talk to people with this disorder about their interpersonal relationships, is that they tend to see things in kind of black or white terms. When they're in one mood state, things can be all negative, all black, and in another mood state, things can be positive. People are seen as all good and all bad. If somebody, does something abusive, it's hard for the person to keep in mind, the nice things that they've done for them in the past. So it's hard for borderline patients to integrate these kind of conflicting qualities together. Now, it turns out that the anterior cingulate area is involved in conflict processing. Now, how do we know that? If you image people, you just take a group of healthy volunteers, and you give them a task to do where they have to make a choice about two possible options. And the two options, the outcome from doing either of these two options are pretty equally desirable. Then there's a conflict, which do they choose? And you find that when people are having that kind of a conflict, that they activate this anterior cingulate region. Also, if people are doing a task and they make a mistake, they hit the wrong button, as soon as they realize they're making the mistake, this area lights up. Again, there's a conflict. Wait a minute, I should have done that, but I did this. This area lights up. Now, the anterior cingulate, the ACC, not only becomes activated, but it then sends signals to higher level cortical processing areas. So from here up to these higher level frontal regions, which are involved in planning and decision making. And so we think that the signals from the conflict area to these higher areas of cognitive function may allow people to handle conflict, to kind of integrate and come to some resolution. So, and this is now very, very highly speculative, but it's kind of interesting to think about, that the borderline patients are not able to activate this anterior cingulate area. Maybe they're not able to bring on board the kind of conflict resolution processes that other people can use, and maybe in some way this contributes to the phenomena that we've been describing in column splitting. This is a picture just showing how the borderline patients do activate the caudate area, the striatal area, more than healthy controls when they're trying to suppress. What I've shown you up to now is the regions that the healthies are activating more strongly. So the borderlines, we get a pretty strong signal here in the caudate. Not sure what that means, but one of the functions of the caudate is to control the initiation of action. So when the borderline patients are asked, suppress your negative reaction to these pictures, the part of the brain that kind of gets ready to control action seems to get activated. And we know that people with borderline disorder tend, when they're under stress, to kind of act out. And maybe this is in some way related to these areas getting drawn in. So I've sort of gone over a lot of material and a lot of details about different regions of the brain, just to kind of pull it all together. When processing negative emotions, borderline patients, we see, don't employ the same brain networks that healthy controls do. Their emotional assessment system, the amygdala, the fusiform gyrus, is really hyperactive. The visual system is hyper alert. And they seem to be using more reflexive, automatic systems in the brain than the sort of cognitive consideration kind of systems of the brain. And then when we're asking people to try to control their emotional reactions, we find that when attempting to reduce negative feelings to emotional scenes, the borderline patients use different areas than healthy controls. They're less able to mobilize this anterior cingulate region. They're less able to downregulate the amygdala. Conflict resolution may be impaired, and maybe they're more action prone because some of the action systems are getting more activated. Well, what are the potential implications for treatment approaches from these kinds of functional neuroimaging pictures? One thing is if you can begin to identify particular regions of the brain that are less active in borderline patients, maybe you can find medications which can particularly activate or sensitize these regions. And another would be from a psychotherapeutic approach. One interesting finding that I mentioned before was the notion that maybe with this heightened visual acuity, borderline people are picking up on these kind of microfacial expressions. Maybe that contributes to why they tend to be more interpersonally sensitive. Well, this could be something one could present in a kind of psychoeducational approach and also in a cognitive behavioral approach. So there can be implications to both psychotherapeutic and pharmacological treatments from some of these brain imaging studies. I want to thank people I've collaborated on with this research. This kind of research takes a big team. Larry Seaver, Antonia New, Marian Goodman. You'll hear Antonia later today. The imaging work that was done with the cognitive reappraisal strategy, Jin Fan, Kevin Guzet, Isaac Prohovnik with the imaging work done with the emotion processing, Kevin Oxner, and then research assistants, Scott Pizzarello, who collected a lot of the, ran a lot of the scans for us. Our new research assistants, Lucia Takuda and Christine Durantes, who are in the process right now of scanning more subjects. And before I stop, I just want to say if anyone is interested in learning more about the research that we're doing or participating in it, here's our phone number, and we welcome calls. Thanks very much.
Okay, we're going to take some questions now for Harold, and we won't be able to address all of them, but let's start with one about does borderlines have reduced cingulate activation and a hyper-alert visual system? Is the opposite true for autism spectrum disorders? Are they, in other words, overactivated in cingulate, less activated visually? Are there other comparisons to patients with symptoms opposite of borderline, unable to note facial expressions?
Well, this is an area that I know very little about, so I can give you a very quick response. I believe that some studies of autistic patients, and Eric Hollander, who's the chairman of a department, is doing major research in this area, imaging research, and his work would really be something I would refer you to. I believe there have been some studies that have shown different activity in the fusiform region, the facial regions that I talked about in autism. But beyond that, I can't say very much.
Are there any drug trials of studies of NET that might target these specific brain areas? You alluded to those as possible targets. Do you have any more comments on that?
There are, we know that the SSRIs, the selective serotonin reuptake inhibitors, target areas in the occipital, in the orbital frontal cortex, in the front of the brain region, sort of right over where the eyes are, that I think you'll probably hear later today are involved in impulse regulation. And these areas are very rich in serotonin neurons. And so those medications target those specific areas. We haven't tried specific medications that we've identified that have targeted the anterior cingulate. The caudate area and the striatal area is richly innervated with dopamine activity, and so one might look, and I think there may be some studies of people looking at dopaminergic-related medications, for example, buprenorphine, which activates opiate systems, is an opiate agonist and antagonist, can affect the dopamine response. So looking at medications like that might be useful.
Yeah, there haven't been as many pre and post mechanistically oriented studies using imaging for these agents. You could imagine the amygdala might become stabilized by mood stabilizers, for example, which affect GABA and glutamatergic systems. So that might be a way of targeting the amygdala that would complement the SSRI.
Yeah.
But there needs to be more research into treatment with some of these imaging techniques before and after to answer those questions. Here's a question. If people with borderline personality disorder are hypersensitive to visual information, what evidence is there that they are reading visual information accurately? And could they be more perceptive at reading emotions than controlled, or are their perceptions inevitably distorted?
I think that's a great question that speaks to this idea that maybe they're reading kind of microfacial expressions, because in a more sensitive way than healthy controls, because the visual system is turned up, the gain of the visual system is turned up. Another interesting question, most of the work that's okay. Antonio New was just saying that there was a study that showed that borderline patients picked up emotions, assessed emotions more accurately than healthy controls, which is consistent with the idea that this gain system is increased. Another area that I think we need to look at is most of the work that's been done so far has been using visual systems, but a lot of our emotional reactions also are based on what we hear, tone of voice, what people say to us, and different brain systems in the early stages are involved in processing auditory cues, and I think that's an area that we really have to start to look into.
I think it's worth noting that most of the time, I think you mentioned this, people are screening out these microfacial expressions because it's not necessarily adaptive to be aware of all the transient negative emotions and reactions that people are experiencing. And the fact that they can't screen them out may mean that they take a predominant importance in the affective coloring of the situation that most people, by screening them out, don't let get into the way of their daily activities. So in a sense, it could contribute, heightened information and perceptual processing could contribute to affectively distorted perceptions of the environment, even though the specific emotion reading may be, in fact, more accurate.
Exactly.
Now, there's another question related to that. Could there be a positive or adaptive effects of these heightened visual responses in, say, psychoforensics or in other areas? What could be the adaptive effects of this kind of processing?
Well, I think that, that too much of a good thing can be bad, that the brain is wired, I think we see that the brain is wired in such a way that when there's something that seems emotionally significant, we can, focus our attention, we can turn up the gain. But if that system is overactive, then we may be overreading situations. Now, from a forensic approach, I'm not sure specifically what the questioner had in mind in terms of that.
My question, and I thought perhaps there could be a positive use of this super-sensitive visual response to give the person with this super-sensitive visual response a positive effect on society rather than have them perceive themselves as
Well, I think one of the things that many of us who've worked with borderline patients have noticed is that borderline patients can sometimes be exquisitely aware of interpersonal situations and kind of very, very sensitive. And if one in treatment could use that and be able to kind of keep it from getting out of control, I think it could be helpful to someone.
Okay. Couldn't cover all of the questions. We will have more opportunity to address questions that came from the audience, and perhaps there'll be some overlap in some of the questions to the different presenters when we have the discussion period at the end. Right now we'll break for 15 minutes and resume at 10:30.